So I came with two cases. The first one is a case for a question. So it's a question for you because I need help. You know, benign pathologies are always tricky for surgeons, and so quite difficult cases. And so I come like Pietro with a question for unsolved situation. So a young man, 32 years old, very fit, works, has normal quality of life, had been operating in 2007 and in 2010 of some kind of surgery where we have absolutely no information for hydatid cysts in the liver, but I have no imaging, no informations. I absolutely don't know what has been performed to him, and the patient doesn't know. He has a subcostal incision, and is all what we know. So this was 15 years ago and 10 years ago. And he came last year with abdominal pain in right upper quadrant and was hospitalized in another hospital in an emergency department where they did a CT scan. So the chest CT scan shows two lesions in the lungs, one perihilar, right perihilar, and one on the base of the right lung of roughly 3 centimeters of diameter. And in the abdomen, you see quite lots of cysts in the liver, transdiaphragmatic, many lesions, one in the spleen, in the peritoneum, and also around the left iliac artery here on the lower part. So those are some details. The one in the spleen and in the spleen hilum is calcified. The others are not. So there are a few which are very characteristic of hydatidosis, like the one in the liver and transdiaphragmatic. So they had probably some kind of surgery in the right liver because there is a real atrophy of the right liver, and the hepatic veins, left portal branch and left hepatic vein are surrounded by cysts. So the diagnosis was, of course, of hydatidosis. So with antibodies, anti-Echinococcus granulosus, which was very high, also positive multilocularis, but it's here the characteristic is really from granulosus, normal hepatic biology, and no abnormal findings. And so he started albendazole, 400 milligrams twice a day, but which he stopped quite rapidly. So at this time, I presented the case at the staff meeting from Besançon, which is the centralization of echinococcosis in France, who gave me the advice, don't touch the patient for the moment, give 6 months or 1 year of albendazole and reevaluate the situation. So, which of course I did, and roughly he stopped and began again and was not, so now it's 6 months that he takes his full course of albendazole with albendazolemia dosages which are normal, no liver function test perturbations, and he did now, so recently, imaging control in the thoracoabdominal chest, thoracoabdominal CT scan. But he came back with right chest pain, non-productive cough, which he didn't have before, no abdominal symptoms, always he still works and has a normal life, no other complaints, and at the biology also roughly normal biology with gamma GTs, which are very slightly elevated. So the CT scan shows still roughly the same situation with the lung, the two lung nodules of 3 centimeters, perihilar and lobar, nothing else. Some kind of pneumonitis described in the CT scan, but no condensation. There is a location behind, around the left iliac artery, which is not calcified, and you see in the liver many cysts, one transdiaphragmatic, but roughly no change after 6 months of albendazole treatment. So my question is now, what to do with this patient? Is there an indication of liver surgery? And if yes, which cyst should we treat? So this is the question for you. I can go back on.
Anybody with a comment?
Yes.
I think we need help from our colleagues in
Yes,
Egypt.
we need Rashad, we need, but Henri BISMUTH also, he's seen a lot of that.
So 32-year-old man, very fit, and I'm scared that the situation will evolve in the time. So my question is, should we try to treat those in the liver and the transdiaphragmatic one? Of course, I think we don't have to touch those which are calcified in the spleen and in the spleen hilum, but what about the others?
Maybe Rashid.
Valerio, I think, yes, to treat the ones in the liver, the one you may treat, you treat. It's better. You know, they may complicate by themselves. Each may have its own potential of complication. So he's young, you say it is 32.
Yes.
It's not difficult to treat.
Yeah.
Of course, he has 2 operations already. But
Not difficult, I would not say that it's not difficult.
I think it's going to be difficult. If this patient that didn't have previous surgery, which you don't know about, he has subcostal incision, he had 2 surgeries before.
Exactly.
So, and the location of the lesions close to the IVC and the hepatic veins, and one which is transdiaphragmatic or is just bulging in the lung, we don't really know. So I would be worried about that. So, so albendazole is good.
Yeah. What about?
Yes, but those patients,
No, I understand it's cyst, but the problem is that we have no idea what was done. Probably deroofing.
yes,
Section
probably.
du dôme saillant.
Probably even more. They burst a couple, and it had into peritoneal spread. But there is Surendra.
I have operated on cases like that after previous surgery in local countries, and in a couple of cases it wasn't so good. Was very difficult. But so I think we have to be ready for that.
Surendra, who wants to speak.
to remove the parasite,
Yeah,
There is
because
Surendra who wants to speak.
this patient is young, and I'm scared that in the evolution he will do a biliary fistula or a lung fistula of the cyst.
But I will resign from moderation if I can't moderate.
Yes, sure.
There is Surendra who wants to speak.
Yeah. So basically, yes, it requires intervention because one which is transdiaphragmatic can rupture anywhere, can rupture into the lung and can erode into the biliary tree as well if it is not done already. I think the leptoscopic approach will be quite good in these cases, and you go one by one. You do one. There is a cannula which is developed, I think if you have heard about an Indian famous laparoscopist, Dr. Palanivelu, and it has got a triple suction. You can go it and puncture directly into the cyst, suck away all the daughter cysts through that so you don't contaminate the field at all. And then you can put the, I put the nephroscope through that and see the inside the cavity, evacuate all those daughter cysts and everything. Once we have done that, then you can
Surendra,
use that.
it's rather difficult to understand. Can you speak slightly more slowly and clearly?
Okay, sure. Yeah, so I will recommend a leptoscopic approach, particularly the one which is transdiaphragmatic, okay? And there is a cannula which is developed by an Indian laparoscopist who is known internationally also, Dr. Palani Velu. This is a big trocar cum cannula which has got a triple suction. You can puncture the cyst directly without contaminating the field, and then you suck away all the daughter cysts and membranes from inside, put the hypertonic saline, and then what I do is I put the nephroscope through that. Okay, because the cannula is inside the cavity of the cyst. You put the nephroscope, look for any residual daughter cyst which you can suck away using a 10 mm suction. Once you have done that, completely evacuate, and then de-roof that. And that's how you deal with each of them. You have to do that. Okay. I think that is the way I do it. And you can see if there's any bile leak or not. If there is nothing, there is no bile staining seen anywhere, then you are safe. You put a drain and come out and again give the course of albendazole. That's how I will approach it.
So thank you very much, but I'm scared that the laparoscopic approach might be quite complicated. He had already 2 laparotomies with a peritoneal seeding, but we can use for sure laparoscopic tools once we have opened. But I think that the upper quadrant will be probably fixed by adhesions, I suppose, but we can try. What would you do with the cysts in the peritoneum and nearby the iliac artery?
Yeah, so one which is near the iliac artery, you can again de-roof it. Evacuate first, evacuate the content, sterilize the inside the cavity and just de-roof it.
Okay, so you would definitely operate him?
Yeah, I will definitely. Yeah. Because this can rupture.
Yeah.
Je peux? May I? So I think laparoscopy is very optimistic.
Yeah.
Personally, I wouldn't try it. He had 2 operations on the liver. My comment is just that this patient doesn't have any infection, no abscess, no biliary obstruction. And I believe that with surgery, you will definitely have drains, possibly bile leaks, possibly abscesses and infectious complications. So you may want to operate on this patient, but you have to tell him that he should be ready for problems.
Yeah, sure.
I will. There is an Italian paper from Ancona reviewing ethanol injection, aspiration of the cysts and ethanol injection. And see? Yeah.
Ethanol?
Yeah. Okay. Ethanol injection on the cysts, alcoholization of the cysts, and showing sterilization of the cysts in 90% of the cases. I'll send you the paper because I saw a patient treated for that, and now with a small residual cyst. But I'll send you that paper. Surendra, do you know of that? And
yeah, so that is called PAIR, and in India, a lot of our gastroenterologist colleagues have used it. So it is meant for the unilocular cyst, okay, uncomplicated cyst. Now, on this imaging, what is there, they are multiloculated cysts. They are not unilocular cysts. So that technique is meant for the unilocular, usually single or at the most 2 cysts, not so many of them.
In fact, that was a risk factor for non-sterilization on the paper. And from Argentina again.
Yes, thank you. Thank you, Pietro. No, just for saying what Surendra mentioned, that function aspiration, injection and re-aspirations, as it mentioned, this percutaneous procedure is only for unilocular uncomplicated cyst. So it is very complex in this case, like it's really can find some communications with the biliary tree, and alcoholization could produce some biliary injury. I want also to clear out. I think that Surendra mentioned laparoscopy, putting the laparoscope through the cyst in an open way. Please, Surendra, clear me this. But what it mentioned Daniel about laparoscopic approach is not that way. It's open surgery and using the laparoscope to the inspection of the inside of the cyst. It's like this, Surendra, like you mentioned.
So there are two ways. What you are saying, yes, if when you put the laparoscope in the beginning, do as a laparoscopy, like go into an area which is completely virgin, and if you can do the adhesiolysis, get it down, expose that area, then you can proceed with the totally laparoscopy. Otherwise, open, come use of the cannulas and other things for evacuation, what you are suggesting. The third approach which I use, which is, if you see this CT scan, the liver, if they can project again, the liver is in contact with the abdominal wall, those cysts which are bulging there. So one of the techniques which I use when it is in close contact with the abdominal wall, you can do the direct puncture under ultrasound guidance. Okay. Once you do the direct puncture under ultrasound guidance, you use the Seldinger technique and keep on dilating it with the Amplar's dilator, dilate it, and then put the cannula, trocar cannula, and the nephroscope to suck away each of them. That's like a closed technique where you don't enter the abdomen at all. So for that, I have to analyze that CT scan carefully, whether that approach can be used or not.
Okay.
Thank you. I think for the sake of time,
Yeah. Thank you very much.
close the discussion. Thank you very much.